I'm Shin from Shin University Hospital. Because of God's help, I am presenting at this precious conference. I would like to thank the KST for inviting me and the two professors who chaired it. Today's topic is new treatment for ABMR, the interleukin-6 inhibitor. First, I give you an introduction. Long-term kidney transplant survival has improved over the decades, but still remains suboptimal. ABMR is a leading cause of late kidney allograft loss, accounting for up to 60% of late graft failures. Treating chronic active ABMR remains one of the major unmet needs in transplant medicine. Despite the high level of unmet needs, there are currently no FDA-approved agent for the treatment of chronic active ABMR. This underscores the need for the robust, controlled clinical trial like IMAGINE to assess novel agent for the treatment of chronic active ABMR. I will focus on the chronic active ABMR in kidney transplantation and discuss how our understanding of the natural history of chronic active ABMR, coupled with the pilot intervention studies, has led to the IMAGINE study. Let's turn to the development of chronic active ABMR. This slide shows the causal pathway associated with graft failure and death. De novo HA-DSA, the most common pathway giving rise to ABMR, in turn can progress to chronic active ABMR, resulting in transplant glomerulopathy and graft loss. Therefore, understanding the natural history of de novo DSA is important to derive novel strategy to both prevent and/or treat ABMR and chronic active ABMR. De novo HA-DSA typically develop after the first month with an average time of onset of 4 to 5 years post-transplant. Correlated of de novo DSA formation and ABMR are HA class 2 mismatch, younger recipient age, preceding TCML, and under immunosuppression. Maintain adequate baseline immunosuppression, inclusive of CNI, is key to prevent both TCML and de novo DSA formation. This slide shows a proposed natural history for graft loss due to de novo DSA. This production of de novo DSA after transplantation is preceded by early inflammatory event, such as cellular rejection and graft infection. In early stage of de novo DSA development, the pathology may appear normal until de novo DSA binding to the vascular endothelium, inducing the vascular endothelial injury through the activation of a complement or the recruitment of innate immunity. Microvascular inflammation eventually leads to progressive tissue fibrosis, resulting in graft dysfunction. This slide shows the schematic representation of the time-dependent frequency of renal allograft histology. Histological finding of chronic ABMR appeared more than 3 months after transplantation. This slide shows the B-cell maturation and de novo DSA production by follicular dendritic cells and T follicular helper cells in lymph node. In step 1, alloantigen from the afferent lymphatic vessels are captured by the subcapsular macrophage and delivered to the follicular dendritic cells. Step 2, then the T cell and B cell activate each other at the TB borders. In step 3, T cell then migrate to the germinal center to become T follicular helper cells. Step 4, when B cells with high antigen affinity are reactivated by T follicular helper cells, then differentiates into antibody secreting cells produce de novo DSA. This slide shows a possible mechanism of chronic antibody-mediated injury by a DSA and complement activation. In step 1, the C1 complex is activated by DSA, resulting in the generation of C3 and C5a. In step 2, C3 and C3b are generated, and C5 is further degraded into the C3, C5 and C5b. C4d remains bound to vascular endothelial cells at the site of complement activation. In step 3, C5b C9 combines sequentially to form the membrane invasion complex that will destroy the membrane of vascular endothelial cells. Step 321. C3A and C5A act as anaphylatoxin to promote the migration of inflammatory cells. In step 322, NK cell and the monocyte which bind to the IgG by Fc gamma receptor produce pro-inflammatory cytokines and increase endothelial damage. This figure shows the pathogenesis of ABML, wherein an autoantibody reaction is presented by the APC to the CD4 T cells, which later mature to T follicular helper cells, amplifying B cell through the interleukin-6/21 activity. This leads to B cell proliferation and differentiation, which in turn generates antibody producing plasma cells. The binding of alloantibodies to the allograft endothelial cells induced NK cells and activation and trigger the complement activation through the classical pathway. A biopsy at the time of detecting de novo DSA reveals that between 25% and 75% of recipients have a subclinical or clinical ABML. In the context of de novo DSA, both tubulitis and transplant glomerulopathy independently predict graft survival. Histology should be reported as a microvascular inflammation, and a diagnosis of ABML reserved for when the HLA-DSA are present. The etiology of microvascular inflammation in the absence of HLA-DSA at this point remains unclear and may reflect several different processes. This slide shows histopathology of ABML. Peritubular capillaritis is shown in A. Glomerulitis, in which the inflammatory cells obstruct the glomerular capillary, is observed in B. Transplant glomerulopathy in the chronic ABML. Global thickening of the glomerular basement membrane is observed in C. Positive image of C4D on peritubular capillaries in an ABML case in D. What is the chronic active ABML? Chronic active ABML refers to histologic evidence of a current or recent antibody endothelium interaction, combined with evidence of chronic tissue injury with serologic evidence of circulating DSAs. Interleukin-6 is one of the essential immune mediators in the maturation of naive B cells into plasma cell, which is secret DSA that damaged the graft. Let's turn to therapeutic approach to ABML and the chronic active ABML. This figure shows the therapeutic approach to ABML. Interleukin-6 and interleukin-6 receptor monoclonal antibodies such as clazakizumab may prevent proper B cell activation or differentiation and affect the production of the plasma cell. Both the plasmapheresis and IVIG can combine the removal of circulating DSA with the immunomodulation of the anti-graft immune response, specifically B cell response. Imlifidase and IgG degrading the enzyme of Streptococcus pyogenes may rapidly reduce or even eliminate anti-HLA DSA and is currently undergoing clinical trial in the ABML. There are currently no FDA-approved agent for the treatment of ABML. In the context of preformed HLA DSA associated early and later ABML, the TTS working group consensus remains plasmapheresis, IVIG, steroid through the adjunctive therapy. Therapy with the rituximab could be considered. Once the ABMR evolved to the chronic active phenotype, the risk of immunosuppression with no proven efficacy of any agent shifted. The consensus to that of the supportive care while maintained optimized the baseline immunosuppression. This slide shows the algorithm for management of ABMR. So it is worth noting that the plasmapheresis, although occasionally considered, does not directly target the underlying cause of ABMR and should be approached sparingly. IVIG may be considered as a treatment option for the chronic active ABMR, despite the limited supporting data. However, it is important to note that IVIG administration is generally regarded as a safety intervention. This slide shows the post-transplant surveillance and management of chronic active mediated rejection in renal transplant patients in Europe. When chronic active ABMR developed, around half of patients received treatment beyond maintenance immunosuppression. This is attributable to the late-stage diagnosis, but also a lack of efficacy therapies. IVIG, apheresis, and steroids are the main treatment prescribed by the physician to treat chronic active ABMR, with half prescribing rituximab. This slide shows the summary of chronic active ABMR treatment. According to the consensus treatment recommendation based on the available evidence and the expert opinion, treatment of active ABMR due to de novo DSA should optimize baseline immunosuppression and manage the non-adherence and adjunctive therapy such as plasma exchange and IVIG. IVIG is recommended as an adjunctive therapy for chronic active ABMR. This slide shows RCT for prevention and/or treatment of ABMR classified by the mechanism of intervention. Clazakizumab comes with a hope of less rebounding antibodies and the rejection than prior interleukin-6 receptor antibodies. Let's turn to a new treatment for ABMR, interleukin-6 inhibitor. Targeting the activation and/or the modulation of antibody-producing cells has come to the forefront as a strategy to treat ABMR. In this context, there is an emerging focus on the interleukin-6 receptor pathway, which has several roles related to the ABMR biology. Interleukin-6 promotes the development and the maturation of a B cell to plasma cell that the product produce the HLA DSA targeting the allograft. This slide shows interleukin-6 signaling pathway. Figure A shows essential feature of the classic interleukin-6 receptor signaling pathway. Interleukin-6 receptor cassette and activated glycoprotein 130 on the cell's membrane, inducing signal transduction pathway, leading to the JAK STAT3 activation and gene transcription. Figure B shows the unique trans signaling pathway which expands the activation capacities of soluble interleukin-6 receptor to nearly every cell in the body. Circulating soluble interleukin-6 receptor bind to interleukin-6 forming interleukin-6 receptor interleukin-6 or the capable of the binding to glycoprotein 130, expressing the cells and activating the JAK and STAT3 pathway as previously described. Figure C shows a recently discovered transpresentation pathway. Briefly, this mode of interleukin-6 receptor, the signaling occurs in the context of antigen presentation by dendritic cells to a naive CD4 T cells. This results in the phosphorylation and the signal transduction by JAK and STAT3 pathway. Activation of these naive CD4 T cells leads to activation of T helper 17 cells, and the induction of inflammation, autoimmunity, and allograft rejection. Interleukin 6 production also inhibit the Treg cells, further enhancing inflammatory injury. Figure D shows the impact of the anti-interleukin 6 receptor and the anti-interleukin 6 antibodies on the inflammatory CD4 T cell inducing by interleukin 6 receptor transplantation. Briefly, anti-interleukin 6 receptor inhibit transplantation. This results in the muted CD4 T cell activation and the deviation of the inflammatory immune response towards a regulatory and tolerogenic type of response. Figure shows the importance of interleukin 6 in B cell development, the maturation, and the relationship to donor-specific TSA development and immune injury to allograft post-transplant. Interleukin 6 production by APC is a powerful stimulus for interleukin 21 the production by the naive T cell. This results in the maturation of naive T cells towards the follicular T helper cell phenotype expressing 6CR positive, 6CR interleukin 21, and the transcription factor the BCL6. Naive B cell migrate to the germinal center in response to 6CR5 positive follicular T helper cell. This activates B cell maturation to memory B cell and interleukin 6 producing plasmablast. The plasma cell has the highest density of interleukin 6 receptor compared with other B cell subset, suggesting the importance of interleukin 6 in the driving pathogenic antibodies and the tissue injury. This slide shows the cell signaling pathway of the interleukin 6. Interleukin 6 binds to interleukin 6 receptor and the glycoprotein 130 to form a hexameric complex. Both membrane-bound interleukin 6 receptor and the soluble interleukin 6 receptor can be part of the hexameric complex and are associated with the classical signaling and the trans signaling pathway, respectively. Intracellular signaling pathway involves the JAK and the STAT pathway. Pharmacological inhibitor of interleukin 6 signaling prevent interleukin 6 from the binding to interleukin 6 receptor by targeting either the cytokine itself or the receptor. This slide shows interleukin 6 inhibitor can block the action of the interleukin 6 either directly or at the receptor level. The blocking of interleukin 6 leads to inhibition of the maturation of naive CD4 T cell into CD4 follicular T helper cell and the T helper 17 cells, which inhibit the autoimmunity and decrease the antibody production and upregulate the differentiation into CD4 Tregs, which suppresses the inflammatory response. The blockage of interleukin 6 also inhibits the differentiation of a naive B cell to the TSA producing plasma cells and the memory B cell. The potential site of immunomodulator action of the anti-interleukin 6 receptor are summarized in the figure. This figure. Effect of anti-interleukin 6 receptor therapy on reducing follicular T helper cell activation and the subsequent plasmablast and the plasma cell development with reduction in pathogenic antibody production and tissue injury. In addition, anti-interleukin 6 therapy inhibits the T effector cell function and enhancing Treg cell or the Breg cell differentiation, which likely inhibit TSA formation and allograft injury. Available interleukin 6 receptor pathway therapeutic agents are summarized in table. After the introduction of tocilizumab, numerous other anti-interleukin 6 receptor therapies have emerged. What is clazakizumab? Clazakizumab is a humanized monoclonal antibody that targets interleukin 6. And the binding of clazakizumab to interleukin 6 may disrupt several steps that critically to T cell and B cell immune responses, resulting in the decreased TSA production. In an uncontrolled cohort of a kidney transplant recipient with refractory chronic active ABMR, all of which had HLA-DSA, monthly infusion of tocilizumab decreased DSA and microvascular inflammation and stabilized the renal function. A pilot study that used monthly infusion of tocilizumab as a first-line therapy for chronic active ABMR. Well, all the subjects had HLA-DSA positive, and the majority had the several PAMP-CG score reported stabilization in eGFR and proteinuria. Finally, a small open RABEL study of the recipients with chronic active ABMR reported treatment with monthly clazakizumab injection. The result in the renal function stabilization, improved microvascular inflammation, and HLA-DSA reduction. This slide shows the efficacy and safety data for tocilizumab for treating of the chronic active ABMR. Study shows that a significant reduction in DSA and microvascular inflammation. This slide shows the outcomes of tocilizumab treatment in a cohort of the 11 kidney transplant recipients with biopsy-proven chronic active ABMR. One of which is 30-60%, had failed the previous therapy for chronic active ABMR with IVIG and/or rituximab. Tocilizumab appeared to reduce the graft injury as measured by dd, cfDNA, and modulate the immune response, as evident by the modest reduction in immunodominant DSA MFI. Overall, tocilizumab was well tolerated and reasonably safe as a therapeutic option in chronic active ABMR. This phase 2 randomized pilot study evaluated the safety and efficacy of the anti-interleukin-6 antibody clazakizumab in late ABMR. Major safety signals were the occurrence of a serious infection event and diverticular disease complication. Key results of a secondary endpoint analysis were an early decrease in DSA levels, a slow eGFR decline, and after extended treatment, modulation of rejection-associated gene expression pattern, reduction of C4D scores, and in some patients, resolution of ABMR activity. 10 adults with biopsy-proven chronic active ABMR were enrolled in a phase 2 single-center open-label study. Patients received clazakizumab 25 mg subcutaneously monthly for 12 months with the 6-month protocol biopsy. In this small cohort of patients with chronic active ABMR, clazakizumab treatment shows a trend toward stabilization of eGFR and reduction in DSA and graft inflammation. This slide shows IMAGINE trial design. IMAGINE is a multicenter double-blind trial approximately 350 kidney transplant recipients with chronic active ABMR randomized 1-to-1 to receive the clazakizumab or placebo. This trial evaluates the safety and efficacy of clazakizumab in preventing all-cause composite graft loss and the slowing or preventing the progressive loss of kidney function due to chronic active ABMR. This trial measured the eGFR slope over the 12 months, which has been accepted by the FDA as reasonably like the surrogate endpoint for allograft loss. Recruitment is ongoing across sites in North America, Europe, Australia, and the Republic of Korea, etc. This table shows the unique feature of the IMAGINE study. Treatment with clazakizumab is a sustained regimen akin to treatment for autoimmune disease, rather than the typical short course nature of current ABMR and TCMR regimen. I'd like to conclude with this remark. Interleukin-6 is a pleiotropic cytokine that is important in both innate and adaptive immune responses. Unique signaling pathway allowed interleukin-6 to rapidly activate any cells expressing glycoprotein 130 and induced inflammatory events. The recognition of the importance of the interleukin-6 expression in endothelial cells and their role in stimulating inflammatory T and B cell activation, and intimal the proliferation of vasculature open and the new vista in explaining the pathogenesis of vascular injury due to antibodies. Anti-interleukin-6 and interleukin-6 receptor treatment can induce Treg and Breg cells in vivo. New studies of anti-interleukin therapy are now underway to determine the efficacy in treatment of chronic active ABMR. It is critical for the transplant community to finish the imaging study to determine the safety and efficacy in a large and rigorous randomized controlled trial. Thank you for your attention. Thank you. Thank you for your attention.